Hi, everyone. Our presentation today is on Duchenne muscular dystrophy. I'm Riley Babiars.
I'm Brooke Hayden.
And I'm Alynna Williams. First off, the etiology of this disease is it is most common and severe form of muscular dystrophy. It is caused by a defective gene for dystrophin, which is a protein in muscles. Without this protein, muscles are not able to function or repair themselves properly. Due to the way this disease is inherited, boys are at more risk than girls. However, when a mother is carrying a child, there is a 50% chance of having the disease no matter the sex, but again, it is rare that a daughter will be affected. 1 out of 3,600 male infants inherit this disorder. There's 15,000 boys in the United States who have it, and there's 300,000 globally. Most boys who have this disorder do not survive past their mid-20s, and they are typically in a wheelchair by the age of 12. The symptoms for this disease appear before the age of 6, but can come on as early as infancy. They are fatigue, possible learning disabilities, and intellectual disabilities. The effect on development: bones develop abnormally, causing skeletal deformities of the spine and other areas. Most importantly and severely is the muscle weakness, and the skeletal deformities contribute to breathing disorders. Progressive muscle weakness in the lower extremities, including leg muscles and pelvic muscles, which can cause a child to have a waddling gait and difficulty climbing stairs. There's also pain in calf muscles. The calf muscles enlarge and the tissue is enlarged, which is then replaced with fat and connective tissue. And the muscle contractures, making the legs unusable, which fibers shorten and fibrosis occurs. There are 5 stages of DMD. The first stage is the diagnosis in infancy. At this stage, children are typically reaching milestones, but with children with DMD, they will present with large calves and use the Gower's maneuver, which is when a child needs help getting off the floor, so they typically are walking their hands up their legs to help them to stand. An increase in the creatine kinase and liver enzymes are also high during the stage, which makes it appropriate to test for DMD. The second stage is early ambulatory, which is childhood. At this stage, the children are typically presenting with clumsiness, they move slower, frequently falling, and asked to be carried frequently. I think that it's important to note that they ask to be carried frequently because a typical behavior of a child is to be asked to be picked up. So I think that that's something that can be a little confusing when trying to diagnose a child with DMD. Also during the stage, they have a hard time climbing stairs, running, and keeping up with their peers. The third stage is late ambulatory, which is late childhood and adolescence and young adult. During this stage, the quadriceps weaken more and there's more difficulty walking. Weight shifting becomes difficult. Belly is sticking out in order to compensate. Trunk support and the use of hands are still present, but are beginning to weaken more. And they are struggling to carry books and other materials during the school day. During the stage also, to increase functional mobility, a carriage, a scooter, a manual wheelchair, or a walker is used to assist ambulating within a classroom. This helps with fatigue. And young adults should begin independence in this stage, managing their own care, future careers, their interests, and monitoring their own health, such as heart rate, bone health, breathing, and puberty is also very important in this stage. The fourth stage is early non-ambulatory, which is adolescence and adult. Teens will start to become more independent and begin making more decisions on their own. This also includes taking care of their medical care, knowing what medications they are taking and why, and figuring out the most appropriate life path and ways to follow it. During the stage, they are using a power wheelchair on a regular basis. They help with mechanical support with activities involving legs and trunks, develop with scoliosis due to weak back muscles and sitting most of the day, and the progression of weakness in the arms continue, but they still may be capable of self-feeding, writing, and personal hygiene. It's also very important in the stage to transition to adult care. The last stage is late non-ambulatory, which is adult. This stage focuses on the adult receiving the care they need to remain as independent and active as possible. So finding a career, having a social life, staying engaged in the community is really important for their quality of life. During the stage, the challenges using their hands continue and the maintaining of a good posture. Weakness still progresses, but for some adults, they maintain some function in their fingers. A supportive care environment, and again, transitional planning for pediatric to adult care will continue at this stage. So the impact on the body functions, they impact everywhere for the brain, the dystrophin abnormalities, possible learning, cognitive deficits. For the heart, decreased heart function, cardiomyopathy, and it can lead to heart failure. Bones begin to brittle. Lungs, a weak diaphragm requires ventilation, and it can lead to pneumonia. And muscles, of course, the muscle weakness, inflammation, and fibrosis.
So, all of the impacts on the body functions that Lean just mentioned can impact occupational performance as well. Muscle weakness and fatigue is one of the most disabling, and that's been reported by people who actually have DMD and their families. This fatigue causes difficulty with ADL and IADL completion, like dressing, bathing, doing chores. It limits their ability to ambulate. As mentioned, a lot of them are in wheelchairs. And ultimately, it impacts their ability to participate in play and social participation. Um, Again, as mentioned, some of the people with DMD can have intellectual disabilities or learning disabilities, but it's also been noted that they have an increased risk of emotional and behavioral problems as well, and this can limit their participation in formal education. And most importantly to note is that there are some psychosocial factors that can limit occupational performance. There is no cure for DMD, and therefore most therapeutic strategies are to delay the progression of the disease and improve quality of life. This is really important because the life expectancy is around mid-20s to early 30s. So an OT working with a person who has DMD has to take their motivation and willingness to participate in therapy or daily occupations into consideration as a potential factor. So this slide, the role of the OT, represents all the things that an OT is looking for while working with someone who has DMD. So what the OT is looking at is they're looking for learning differences, attentional issues, sensory processing issues, fine motor, ADL, computer access, swallowing and oral motor dysfunction, and transitioning.
So some of the assessments and screenings that are helpful for children with DMD is goniometry. So this would be useful for the baseline limitation of movement, as well as manual muscle testing, which is going to assess muscle strength. Range of motion, which is the ability to move the body in space, and an expected range of movement. This would be also important to see their ability to move against gravity, as well as a timed up and go. This is usually used for older adults. However, I thought it'd be useful for children with DMD because it assesses mobility, balance, walking ability, and fall risk, as well as assessing for DME or ADU. So most children, like mentioned before, with this condition will need a wheelchair by 12 years old. Some other assessments, starting off with the AMPS. So this is more of changing and maintaining body position. So it's an objective assessment of motor and process skills. This can establish a baseline for performance and evaluates for change in performance. It measures the quality of a person's ADL performance in general. The next is the PASS. So this is going to be more of a self-care assessment. So it's an observation-based performance rating of ADL function, and it can be used in different settings like the clinic or the home. So it measures the occupational performance of daily life tasks in a variety of settings and can be beneficial for seeing the child in all their environments in order to give the best client-centered care. Next is the BOT2, which is focusing on motor functioning and motor proficiency in both gross and fine motor abilities. So the fine motor and gross motor is evaluated in game-like task, and it's going to be easy to administer for the child. The next is the clinical observations of motor and postural skills. So this is a screen for presence or absence of motor problem with postural components. So it's a screening tool with children with motor and coordination. It generates a score that would help identify subtle motor coordination problems in children, and this can be useful in the earlier stages to detect these challenges in these children. The last one is, developmental programming for infants and young children. So this is going to be providing developmental norms and milestones. So this assessment can be useful for infants and young children when determining developmental milestones, like mentioned before, another slide, that children with DMD may not be reaching the milestones. So it assesses domains of development in perceptual, fine motor, cognition, language, social, emotional, self-care, and gross motor. And then finally, the last one, occupational therapy, psychosocial assessment of learning. So it examines environmental factors to determine the best fit for the child and their environment. I think this is a great tool to use for being an occupational therapist because this assessment uses observation and interviews to evaluate a student's volition, the ability to make your choices, habituation, which is your roles and routines, and the environmental fit within the classroom setting.
So I think it's very important to mention exercise for these children. No exercise for them can also be very dangerous because it can contribute to muscle atrophy, weight gain, and depression. No eccentric exercises is very important, such as lowering a weight down, walking down a steep hill, or any exercise that occur a lot of breaks in muscles. And once the child is cleared by a cardiologist, there are aerobic exercises, passive range of motion and active range of motion, and the stretching of the heel cord to avoid stiff ankle joints. So as much as no exercise can be dangerous as well as exercise, there has to be some type of um, area where you can meet in the middle with these kids because they still need to be active.
Going off of Alynna's slide, some evidence-based interventions. So assistive devices. An example is assisted standing devices. So supported standing devices for individuals with no or to mild lower extremity contractures are necessary for late ambulatory and early and non-ambulatory stages, including standers and stand and drive motorized wheelchairs, extending benefits previously reported with the use of knee, ankle, foot orthoses. The next is gentle exercise. Mentioned in the previous slide, there needs to be an area that you meet in the middle with a child where they are being active still, so home-based cycling programs, orthotic and splinting. So examples of these are AFOs and KAFOs. So the main types of orthotic devices are ankle foot orthoses and knee ankle foot orthoses. There are also wrist and thumb splints that can be used to enable those with weak hands to grab smaller objects, as well as a shoulder sling can help in supporting arms and ligaments in those with weak shoulders. The next is pain management. Some things to focus on is postural correction, orthosis, wheelchair, and bed enhancements, as well as pharmacological approaches. So this could be muscle relaxants or anti-inflammatory medications. It's important to note that adaptive equipment and assistive technology should be used to emphasize the prevention and management of pain and optimize comfortable function and movement with transfer, bathing, and toileting equipment, as well as other ADL equipment. The last one on this slide is maintaining skin integrity, which is going to be more for the non-ambulatory stage. So the child will most likely be confined to a wheelchair around the age of 12 years old. So we can help maintain skin integrity in this stage. So the maintenance of skin integrity includes power adjustable beds with pressure relieving mattresses, bathing and toileting equipment, lift or transfer devices. It's going to include hydrolytic or motorized patient lifts, ceiling lifts, slide sheets, and environmental control options. Some other interventions, so participation at school. This is going to be more of a school-based approach. So we can provide ways that the child can mobilate around the school. This can be helping, assistive device or wheelchair fit. We can do manual therapy techniques. So this could be stretching to minimize and prevent the contractures. Maintenance of chest wall mobility. This can be for more of the later stage when respiratory management is needed, as well as bed mobility. So is the patient able to lift up their blanket? So an example is blanket lifter bars. And the last one is fall prevention.
So some additional information that we thought would be resourceful is Becker's muscular dystrophy. It's similar to Duchenne's muscular dystrophy, but it's a milder form. So in DMD, there's the absence of dystrophin. In BMD, it's still being produced. So like there's still partial function. Because of this, the effects of BMD do not manifest until later on in childhood or early adolescence, and the rate of the progression is much slower. Individuals with BMD can reach to like early 40s, and pneumonia is usually the cause of death, whereas DMD is around early 30s or mid to late 20s, and it's usually the cause of death is usually cardiopulmonary compromise. In the next slide, we have a video. We're not going to play it right now, but you guys can click on it later on or watch it whenever you want. It provides more information on the manifestation, progression, and implications of DMD and BMD, and it goes in deeper in the differences between the two. And then next, we have a couple practice questions for you guys. So the first one is, Jason is a 5-year-old boy who is sitting on his kitchen floor. When asked to get up from a sitting position, Jason moves his hands on his legs as though crawling up to the thighs and then assumes a standing position. What trait of DMD is Jason displaying? So the answer for this would be B, Gower sign or Gower's maneuver that was mentioned earlier in the PowerPoint. The next question is, an occupational therapist is working with a client recently diagnosed with Duchenne muscular dystrophy. The therapist wants to assess the child's motor functioning and proficiency. Which of the following assessments will be best to use? And the answer to this one would be D, BOT2, and it was mentioned earlier in the PowerPoint as well by Brooke. Lastly, Luke is a 17-year-old boy presenting muscle weakness and fatigue. He indicates that he is experiencing frequent falls and finds it difficult to climb stairs. Genetic testing indicates that Luke has inherited an X-linked recessive gene causing his condition. What condition is Luke likely to be diagnosed with? And the answer to this one is C, Becker muscular dystrophy, because the onset of his symptoms were not until later on in life, whereas Duchenne muscular dystrophy, it would be early childhood. And then the next slide, we have our references, and thank you for listening.